I think we're live. We are live! Hurrah! Sorry for the little delay there. Hello and welcome to our YouTube live Q&A for Centre for Mental Health. We are really excited to have you all here watching today and watching back. And we are really happy to have Nick O'Shea here. He's our chief economist and he did the modelling for our latest research, which is our latest forecast of the mental health impact of the pandemic. So Nick, thank you for joining us today. You do have a very busy day, so we're very grateful. To everyone watching, please put your questions to Nick in the chat on YouTube, or alternatively, you can tweet us at Centre for MH, and we'll do our best to get through all those questions. But I'm just gonna jump right in, Nick. So we released this briefing on Wednesday. Can you just talk us through the kind of key figures that we've seen as a result of this modelling?
Sure. So the idea of this whole process is, and I would say, is that economists don't really like forecasting. We like to tell you why there have been problems. We don't like to tell you what might happen because it could be wrong. Economists hate being wrong. But this is really a model that we've devised working with colleagues in the NHS, led by a team by Paul Bibby, which has really tried to take the most robust research we have on individual groups of people who have experienced COVID, and to then surmise from that research what we think is going to happen in terms of mental health services demand. So my job was to put that into an Excel spreadsheet, and row by row is to have, groups of different people, what we think is going to happen, how that then goes into a service demand piece, if you like. And then at the other end, you then get these figures that tell you this is the number. And when we did that back in October, I mean, COVID was just so new, in October last year, it was 6 months, so 10 months old in terms of globally, but 6 months old in terms of us. And, we said 8.5 million adults was the equivalent amount of capacity we'd need, plus 1.5 million children. And, and that's sort of over a sort of 3 to 5 year period. And that's amazing. It's a big number. Yeah. So when we then redid the model to sort of get more the newer research in, and as more time goes by, more research is coming along, actually it was really surprising to see that the numbers pretty much held static for adults, which is where we've done the most work. So the children's forecast is the same, but for adults, it's pretty much remained the same, even though we've got much richer data and much more depth in terms of the robustness of the figures. So still this 8.5 million figure, much of it driven by people with existing mental health problems. And we know that there's been a sort of a dip and then a rise in the number of referrals, but also other groups around people working in frontline healthcare services, people who are carers, and young people. But we'll come on to that. So 8.5 million is your figure, and then 1.5 million children and young people.
So we're talking 10 million people.
Yep.
The equivalent of 10 million people who will need some sort of mental health support as a direct result of the pandemic. And I guess within that, my understanding is that you have gone into various groups that we'll talk about, but also you have sort of differentiated, you've kind of looked at the general population, and within that as a group, people who have existing mental health conditions as well before the pandemic. So could you just tell me a little bit about that and how they specifically would be affected?
Yeah, so I mean, it's not looking terrific in terms of that group. So essentially, you've got the general population, and then roughly 7.5 million people with mental health or mental illness, mental health problems underneath that, and that population of people, would be in treatment and would have existing problems. And then obviously there's been a year where there's been, lockdown, difficult to access services and so on. And what the research shows is that it's around anxiety and depression are where we've predicted, quite a big impact in terms of the numbers. But that's not to say that things like psychosis won't get worse. It's just that in this model, we've only used the robust research that we have, and it's on anxiety and depression at this point, and PTSD. But that's what we see as sort of driving that at the moment. As you sort of go along the list of people, it's then frontline workers. So there's 2 million people working in the NHS and social care services. It's a big group of people, and what we've done there is to categorise it into people who've been working in ICU wards, which is a deep personal concern for me. I think that's been a very traumatic experience for people, and easily forgotten, weirdly. I think we just kind of go, oh well, that's over. But no, it's not over for those people. And then people who've then been hospitalised, by the virus, people who have been on ventilators, which we know brings a lot of trauma, and then obviously people who've been bereaved. And it's quite interesting to look at the bereavement section, because what you've got there are people who not only have you experienced loss, but then you've got two things, which is one is not being able to be with a person or having to say goodbye on a video call, which is horrendous but necessary. But secondly, this idea of, because COVID is a transmissible disease, people having survivor's guilt. So this idea that I gave it to them, it's not true. It's a virus. If we knew how to control it, we would have done much better. That's not the case. But people have this very strong feeling, and those are the things that will feed through into mental health treatment as we go along. It is worth just saying that in terms of looking at the model, the numbers, there's 13,000 people working in ICUs, for example. The numbers of those subgroups are quite low. So what we've done is just taken them off the general population. So in theory, you could have someone who is, working in an ICU, who's been bereaved, and who is a carer of someone with a learning disability. Yes, they would be in that 3 times. But we decided on this occasion that the numbers are so low that actually the cross contamination isn't, in terms of statistics, is not that high.
Yeah. Okay. Yeah, that's really helpful, Nick. And I think, and especially kind of, as you say, if you actually look at what people have been going through, it's really, obviously it's not a surprise that people are going to struggle with their mental health more. I guess what we're doing here is just trying to really quantify that, put some actual numbers to that. And the work that you've done has helped us to kind of help, could really help services to plan for the demand that we're likely to see. So another question was just just helping us to understand how you've come to those figures.
Sure. So the idea is that the model is very simple, so that actually if you disagree with how we've done it, well, A, it means you can see how we've done it, and B, if you disagree with it, you can change the model because it's an Excel spreadsheet. So if anyone likes Excel, it's there for them to change. So the idea is so we take the research, and the team have gone through over 200 pieces of research. It's been an immense piece of work, and then that gives you this prevalence rate, I guess, for what we're expecting to see as a result of the pandemic for that specific group of people. Then for the national forecast, what we've done is taken the number of people in the country, in England, who have got that particular job or that particular issue, and then you apply the prevalence rates. What we then do is take 3/4 of that number off. So because we presume that 3/4 of people won't access services as a result of what's happened. So someone may have extreme trauma as a result of bereavement, but actually they either deal with it privately or they get help from a non-NHS provider. So it's this idea that actually 3/4 of that group are out. So we're only taking 1/4 through. And then it then goes through into, there's a further column which is optional, which is you can assess, if you're a local area, assess the years where you think these things will happen. So we would expect that anxiety and depression would be front loaded into the sort of years 1, 2, 3. Post-traumatic stress, we know, doesn't appear for a few years, so you might put that into another year. And then there's a discount factor, which is if you think there's a massive overlap between two groups, you can just pop that in, and that will, again, it will limit the numbers down. So you do start off with big numbers, and I know it's a big number at the end, but we really do take out a load of people as we go along. I really do. And it is this idea of, the research, it's a novel virus, and so the research is super new, and so we are just trying to use the most robust things that we have. What I can't say to you is it's 8,200,454 people in years 4, 5, and 6. I can't do that. I'm not Jeremiah, but what I can say to you is this is an idea of scale. This is not going to be business as usual, and I think maybe there can be a sense that disparate, you're going to see economic disparity result from COVID-19. That's going to be the key thing. Some people have done really well, some people haven't, and it's going to be exactly the same for mental health, is disparity. Some people have had a terrific lockdown. My neighbours have discovered Greenwich Park and upgraded their cars. They've had a great time, and that's great, good. I'm delighted. But simultaneously, it can be true that people have had a terrible experience of this, and lives have been ruined. And I suppose it's just sort of trying to sort of reflect that actually that number is quite substantial now. And yes, some people, it's been great, but over here is a group of people who aren't going to fit into current capacity. And we are looking at a system where we know we've got staff vacancies. We know there are waiting lists. We know that, perhaps the system wasn't quite in tip-top form before we went into this, putting it politely, and therefore these things are now going to slightly converge.
Yeah, and that's shocking as well, I guess, to think about. I mean, 10 million people is already a really heavy number, isn't it? But to think that, I think, as you said, that that's only a quarter of the people who actually may have some sort of mental health difficulty as a result of the pandemic. I mean, this is, it's lovely to speak to you, Nick, but this is a really somber figures, and I think this is why we are raising this research and raising this analysis, because it is actually vital that investment is made now. And so before we get too much onto that, just tell me quickly, because I know that you mentioned that the figures haven't changed, the overall figures haven't changed, but let me just tell us a bit about what has changed since our forecast in October. And I should say, by the way, if you are watching live on YouTube, you can stick your questions in the chat if you've joined us since we started, and we will do our best to answer those. But yeah, so go ahead, Nick. Sorry.
Lovely. No, it's remarkable technology. I had no idea it all existed. Anyway, but there you go. Yes. So I think, what has changed is we've been able to reduce the reliance on what we expect the sort of general population effect to be, if you like. So in the first forecast, the general population, we kind of had a general figure, which is quite large, whereas in this one we've been able to take more people out of that group, because we're saying, actually, what about trauma surgeons, and what about carers, and so on. So I think it's been to really identify specific groups of people that perhaps are emerging that we should be more concerned about than we had realised in October. So the main groups are frontline workers, so people really who've been, I would say, treating the dying, I think, is in whichever context they're in. So whether that's in a hospital or that's in a care home, people in a care home, for example, who are either having to live there and watch half their residents die, or are coming home and then a family member gets COVID, and these kind of complex nightmares that actually are only 6 months past, and for me at least feel like a long time ago, but are very real. Young people, crucial. Again, it's this idea of, I think there's a lot of attention around people who are at university and how we help those people, but actually there's a whole group of people that aren't at university, aren't in colleges, aren't in jobs, and actually what does their future hold? And we only have to look back to the early 80s in some of the sort of regional towns in England to see what happens actually when you have economic catastrophe, and how that impacts on young people, and those lives just do not improve over the long term. So they're the kind of main groups. I would say that's really sort of comes to the fore. So people who work for the NHS and young people.
Yeah, and that's really helpful. Thank you, Nick. And something that I think you did mention earlier, another question here was about why we haven't got more kind of information on children and young people. That you mentioned that figure hasn't been updated. Could you just talk us through that? Yeah,
simple answer is that the team felt that the research we had was the best on offer at the time, and it's really hard when research takes a long time. Good research particularly takes a great deal of time, and a lot of, fair play to the academic community. They've, from a standing start, they've kind of had to go, right, let's go, and it's only really sort of now that some of the bigger numbers are beginning to come through, because simply you need to see what happens to somebody over a 6 to 9 month period. Well, that brings you right up to Christmas, and we're only in May. So that's why we're stuck with what we've got at the present time. I think the crucial thing about a forecast is there's not just one and then that's it. You have to do them again and again and again. And I think what I say to you is the power of this model is how local areas use it to inform what it is they're doing. And I think as more research comes on, we can update the model, but actually what's more important is people should be looking in their local areas and saying, is this coming through? Where is this coming through? So we're giving you some pointers. We're saying, look out for NHS staff and young people. Okay, how's my system going to tell me which young people, where are they appearing? What's the need looking like? Is that information looking comparable to what's forecast or not? So that's the exercise actually, that's the key thing, is how do you substantiate what's happening in your area? Because if you're not hearing that, then you're not going to know what services you need to be putting in place.
Yeah, thank you. And I do want to come on to that if we've got time, just a little bit about kind of applying this in local areas. But I did just have a question here about, and we know another gap in the data was about people from racialized communities. And I was just thinking about, they have obviously been especially affected by the pandemic in multiple ways, many people from racialized communities. And it would be really useful to have some more data on that. And obviously we haven't really shared that in the briefing. And could you kind of talk us through that a little bit?
Yeah, I mean, it's of everything, actually, it's the biggest disappointment. So having just said how great the research community is, a massive disappointment is for me and for us all, I think, is this lack of data around different communities. And it's not a matter of just sort of saying, well, white communities and then non-white communities, like everyone in that group is just exactly, one other type of person. It is that thing of, well, how do you work out the impact on Bengali communities in this area? And I think this virus has exposed weaknesses, and whether that be physical or mental or economic. And I think one of the weaknesses it has exposed is actually there just wasn't a platform ready to roll for people to just be like, right, we're good, we've got the funding in place, let's go, we know the groups, let's work with this community and find out. And that's very illuminating, I think, and it's a real problem, because the choice you're left with is, do you say, no, we're not going to do any more forecasts until there's some proper research, which is what you feel like doing? Or do you say, well, fine, we've got to get this out there anyway, but there's this big gap, and that's what we went with. And it's as I say, it's my number one thing I'm cheesed off with, really.
Yeah, well, thanks for explaining that, Nick. And I think as we've said before, at the Centre for Mental Health, it's something we are really really keen on pursuing and focusing on, is this racial inequalities, but also the complete inequality in even just data and research on these groups. So we said a lot on that. I can add some stuff into the chat about our work on anti-racism, and but we've had another question here from John Kelly, who was wondering if you could explain why eating disorders weren't included in the model, and kind of what further research may be needed to enable that.
Yeah, so fair question, especially as I think we've seen with young people, the number of eating disorder, the delays for people getting eating disorder services on an emergency basis is going up and up and up quickly. Is the lack of research. So, there are studies on it, but it's just felt that in the round that it wasn't there in terms of robustness for us to be able to include it. So it's as simple as that. And this does come back to this point of, we're sort of giving you a chassis. I'm going to use a car analogy here, not very helpful, but we're giving you a chassis, but actually what matters is what you do with it and what you put around it, and actually how you then say, right, yes, eating disorders is going to be a big problem. So what's the local intel we have for our area that's telling us this is what we need to do?
Yeah, okay, that does make sense, and thank you, John, for that question, but also thank you, Nick, for kind of explaining that. And that kind of leads us really well into questions around how sort of integrated care systems and other sort of local health providers, voluntary and community sector, how all of these organisations can be using the figures that you and NHS colleagues have come up with to actually anticipate and prepare for increased demand.
Yeah, I think so. I think the time is now would be my first message, is like let's do this now. And yeah, I mean, I think we all know that, Rishi Sunak could say, let's have £1 billion trillion and put it into mental health services, and actually that's not going to solve the problem. Is, there's issues around staffing, coverage, and how you would actually deliver this stuff. So I think it is going to be learning from the pandemic itself, which is, you've seen people come out of retirement, volunteer. Most vaccination centres seem to have 4 million volunteers in them, which is amazing. It's brilliant. But actually, how is it that you get these groups together and you use community groups, faith groups, to actually tell you where the need is? Number one, what's your intelligence on that issue, and then number two is how you can support. So, from an economic standpoint, we know return on investment is 3 times higher when you do preventive work and enhancement work. There's a lot to be said for exercise, youth clubs, mentoring, all these things that, we know work, and over the last 10 years have disappeared. But actually, and in terms of the point before about different communities that aren't heard and don't get much exposure, actually engaging with community groups and community leaders is a very quick way to do that, and just trusting people, I think, and saying, well, you know, we know, newsflash, we know this is going to be a massive problem for the next 2 years. What do you think? What would you do? And can we fund you to do it? And that's what seems to have worked on a practical basis with things like the vaccine rollout. So why not try it for mental health?
Yeah, that makes sense. And I guess, sorry, I'm just looking through.
That's fine. It's quite difficult to do questions and ask them.
I know, I'm sorry, I didn't think
I don't think I'd be able to do it.
So no, that is helpful to know. And I guess you sort of said there a little bit about local communities and what they need to do. And I think you mentioned this earlier, but you did say something, I think we've said in the briefing, that capacity seems to be exceeding what we expect demand to be. I know that NHS have pledged more investment. We've got the long-term plan, and we've also got the mental health recovery action plan. I guess, without giving you a leading question, is that investment going to be enough?
I think no, but I think it's this issue of how do you know what it is you're buying, you know, and actually, so for example, you know, what would an outcomes framework look like? How do you know that actually if you put £1 billion into young people, what will that achieve? What will that do? What will that achieve? And I think there's something about that. And then I think there's also something about how you have a dynamic approach to labour forces, to labour markets. So, you know, all right, you can bring some people out of retirement, that's fantastic, but actually, you know, how can you be fast tracking people more into mental health provision? But also, what's the kind of, you know, technological ways we can do? You know, why can't someone just deliver a counselling session for a trust in London and then do one on Zoom in Cumbria and then do one over there? You know, these things just seem to be impossible. Or why can't we just provide routine weekend and evening coverage when we know that actually people want to get this kind of help? Mainly because it means they can keep doing their jobs. They don't take time off work to go and get therapy, which is, you know, employment being a protective factor. So I think it's as much about the implementation plan. Like, what is the plan? What is the actual plan? And then how much will it cost, as opposed to quick, we need some money and anything will do.
Yeah. Okay. Yeah, that's helpful to have that clarification. I think we're going to wrap it up very shortly, unless you've got any more questions. Do put them in the chat. I'm just checking through. Yeah, I think we're good then. I feel like there were other questions I wanted to put to you, but I can't even remember them now. But yeah, thank you so much for your time, Nick. And I guess to put you on the spot here, if you had one takeaway point from this, what do you think it would be?
One. I think if I had one point, it would be substantiation. You know, we've really got to understand, it's to some extent, it's no good saying 1.5 million children and young people if you then can't identify who they are, where they are, and reach them quickly.
Yeah.
And it's that thing about how do we get systems that listen? So, you know, the police, emergency wards, schools, jobs, you know, employers, how do we know who needs the help and when? Because if you don't know that, then it's scattergun approach. So it's the substantiation and evidence, and you know, and it's what businesses do. They understand their customers, you know, and it's about actually, you know, where are these people and how can you get to them? So that would be my point.
Yeah, Nick, thank you. That's really helpful. And what's funny is that we have actually had a final question come in after that, and this is live, people. So here we go. So the question was, what does the forthcoming legislation for ICSs need to do to incentivize the local investment that you spoke about in prevention and early intervention?
I mean, it's like every great. Happy Friday. I think yeah, it's a great question. I mean, I think it's about, there's an opportunity, and then there's the chance of missing it. And I think it is this case of, you know, if we're bringing all the money together, I'm a firm believer, and the economics shows that if you treat physical and mental health problems collectively, healthy mind, healthy body, you know, it works, and it's economically viable. And I think it's about how ICSs prioritize mental health and the delivery of it in this place-based way that there is. But I think, how do you do that consistently? Because that's great if you've got someone who's like really passionate about mental health services, but what happens in an area where actually people are really passionate about something else? And it's this consistency. You know, how do you know if you pull a lever in Whitehall that actually, you know, it's going to be a sort of consistent thing up in Leicester and then Plymouth? And I think that's probably the opportunity. Is you don't want to tie people into, you know, tick this box, but equally, if you don't really ram home that mental health is going to be a crucial thing along with waiting lists for operations, then ICSs, I think, will probably get other things too. There'll be plenty of things for them to be doing.
Yes, well, indeed. And thank you, Nick. I feel like you've answered a lot of questions that I've put to you. And I feel like there are a lot more questions that have come from your answers about what needs to happen going forward. But thank you so much to you for doing this, but also thank you to everyone who's been watching along. We really appreciate it. There is a lot more information on our website. You can go to the website and there's topics, and there's a COVID topic, which has got everything we've been doing from research and blogs and updates, including our latest publication, which you can find all the details on there. If you have any more questions, please do get in touch with us. It's also worth saying that the model that Nick and NHS colleagues have been using and have updated is available in a PDF format on our website, and we will be publishing an Excel version of it so that local areas can exactly do what Nick said and kind of model the numbers of demand for each area. So please do use that, and get in touch with us if you have any more queries or comments. But Nick, thank you so much for your time. We really appreciate it, and